I wanted to put together a little bit of a presentation, like talks about different types of benzodiazepine users and how you may approach the interactions between psychedelics and benzodiazepines, depending on the type of case that you're dealing with. So here's case one. Cece is a 20 or 8-year-old female. Excuse me, she has a history of depression and anxiety. She has tried several antidepressants, although do not produce helpful effects, and she's currently not taking one. She'd like to work with psilocybin. Her current medication regimen is lorazepam, which is Ativan. It is a benzodiazepine, 0.5 milligram as needed, but she only uses it once every other week. So how would CC approach work with psilocybin? Case number 2. So LB is a 38-year-old male with a history of anxiety and neuropathic pain. The neuropathic pain happened after a motor vehicle accident, who's thinking of working with MDMA in about 6 to 8 weeks. His current med regimen is a 0.5 milligram of clonazepam or Klonopin, which is a benzodiazepine, twice daily for anxiety, 600 milligrams of gabapentin or Neurontin, taking that 4 times daily, either for neuropathic pain or anxiety. And he's freshly tapered off of an SSRI or Lexapro. So that was discontinued 4 weeks ago now. So how should LB approach his work with MDMA? In case 3, we've got TK. She's a 59-year-old female who's considering work with ayahuasca. She has a long history of severe pain, trauma, surgeries, anxiety, and insomnia. Her current medication regimen is, looks like she has some opioids or Percocet 4 times a day as needed. Alprazolam or Xanax, so this is the benzodiazepine, and 3 to 4 milligrams a night for anxiety or sleep. And Zolpidem, which is another sleep aid, used at a dose of 10 milligrams at night for sleep. So how should TK approach work with ayahuasca? So keep these 3 cases in mind. I'm going to give a little bit of a discussion about benzodiazepines and psychedelics, and then we'll loop back to the cases at the very end and kind of reveal essentially my thoughts about the cases. I have benzodiazepines here on the slide. My laser here. Yeah, so here's the benzodiazepines on the slide. They're pretty commonly used. Gabapentinoids also work. So let me back up here. All of these drugs here on the slide are GABAergics, meaning that they facilitate or increase the neurotransmission of GABA. GABA is an inhibitory neurotransmitter in the brain. So a lot of these medications have anxiolytic or decreasing anxiety, sedative or hypnotic types of properties. So they're mostly used as anxiety agents or as sleep aids. And so we did see that one of our cases was on a bit of gabapentin or Neurontin as well. And then our third case was taking Zolpidem or Ambien, which is a Z-hypnotic. So all of these are GABAergic agents, and we're going to focus on benzodiazepines, but we'll kind of touch on some of the others towards the end. So what are benzodiazepines? Sometimes you may hear them kind of colloquially referred to in the news as chill pills. I mentioned that they facilitate or increase GABA neurotransmission, and GABA is the major inhibitory neurotransmitter in the brain or the central nervous system, and it tends to have a global calming effect on the brain. So for the purposes of this presentation, all of the people were taking a benzodiazepine either for anxiety or maybe to also like help with sleep. But benzodiazepines are effective in managing seizures. Seizures are essentially electrical storms. There's a lot of neuroexcitation happening. So doses of benzodiazepines can be used to manage seizures. They're also used extensively in hospital types of settings for sedation, as well as to manage, agitation or situations in which people are hostile and combative and may pose a danger to themselves or others. So benzodiazepines, although for this presentation, I'm really talking about their use in anxiety disorders mostly, do have a lot of great therapeutic uses actually in other types of settings for other indications. You know, if you hang out on psychedelic forums, you may see benzodiazepines referred to as trip killers. And they're referred to as trip killers because they acutely diminish effects of psychedelics. And, you know, this seems to be like almost global, like across the board. So, you know, whether it's MDMA, psilocybin, LSD, ayahuasca, all of those psychedelics essentially have diminished effects when a benzodiazepine is administered. And so there are hallucinogen research guidelines out there that have been published. And, you know, first line support or first line treatment for people that are having, you know, a lot of challenging emotions or even, you know, straight up bad trip with psychedelics is emotional support. So getting them to a calmer environment if they're not already in a calmer environment, and you know, just using emotional support is the first line. But you know, when people are, you know, agitated to the point where they're hostile, combative, posing a danger to themselves or other people, the hallucinogen research guidelines actually do recommend using a benzodiazepine in those circumstances. So I guess the point here is that we know that there's probably an interaction between benzodiazepines and most psychedelics in that benzodiazepines diminish effects of psychedelics. On top of that, benzodiazepines are known to interfere with psychotherapy. So there's worse outcomes from cognitive behavioral therapy as well as trauma-focused therapies in patients that are taking benzodiazepines versus ones that aren't. And so benzodiazepines are sedatives. They may reduce the ability of people to engage in therapeutic types of modalities. And beyond that, they have effects on memory. And the Veterans Affairs Administration or the VA recommends avoiding use of benzodiazepines in persons with PTSD or post-traumatic stress disorder. So they have data that essentially shows that the harms of using benzodiazepines in persons with PTSD tends to outweigh the benefits. So, you know, beyond using a psychedelic-assisted psychotherapy to help with PTSD, you know, you're going to accompany that supportive psychedelic session with kind of trauma-focused psychotherapy, and now you have benzodiazepines potentially diminishing the effects of the psychedelic itself, and then potentially interfering with the therapy that goes on before, between, and after psychedelic sessions. Benzodiazepines are Schedule 4 substances, so they can be habit-forming and addictive. So I think what you may be taking away from this slide, and you would be correct, is that use of benzodiazepines alongside psychedelics or in conjunction with psychedelic-assisted psychotherapies is perhaps not ideal. So, okay, using benzodiazepines with psychedelic-assisted psychotherapy, maybe that's not ideal, but you know, what does the flip side look like? You know, what are the kind of like risks looking like? Well, as far as like an interaction perspective, like combining it with psychedelics, it's not physically dangerous, right? The exception may be increased risks of sedation with ketamine, and I have a feeling that this is pretty high doses of ketamine and pretty high doses of benzodiazepines. You know, I think regular doses of benzodiazepines probably just diminish some of the psychedelic effects of ketamine as well. So, okay, it could hinder a therapeutic process, but stopping benzodiazepines is no joke for a lot of people. The withdrawal syndromes can be pretty bad or even medically dangerous. So stopping really is a risk versus benefit decision, despite our knowledge that it's probably not ideal to have benzodiazepines around for psychedelic therapies. You know, the Global Ibogaine Therapy Alliance, or GITA, recommends to actually continue benzodiazepines if you're treating an opioid use disorder with ibogaine. So essentially, they're kind of like, we're just trying to detoxify the person from opioids here, and the person should just continue their benzodiazepines because we really don't want to combine or stack withdrawal syndromes on top of each other. And, probably just be impractical for the person to beat the opioid use disorder while also, trying to discontinue benzodiazepines. And, depending on what the benzodiazepine is used for, so, okay, a small dose for a mild to moderate anxiety, oh, maybe you would really consider tapering it. But if benzodiazepines are being used to treat seizures, then it's probably not appropriate to taper them off, because you're just too likely to run into seizures as a consequence of withdrawal and stopping. And seizures and epilepsy are also conditions that may have some risk of interaction as far as like a drug and disease state interaction with psychedelics. The psychedelic trials have all excluded people with seizure disorders. So in the study so far with benzodiazepines, they've stopped them at least 5 half-lives prior to using a psychedelic. In some of the MDMA-assisted psychotherapy trials, they did allow people to resume their benzodiazepines or sleep aid like Ambien or Zolpidem in the week after their MDMA session. And there was very little indication in those papers that affected the clinical trial results in any way, shape, or form. So it does seem that we know that, okay, people that are using benzodiazepines, maybe they can taper off and that would be ideal. Or, maybe just discontinuing them for a shorter period of time and allowing them to resume afterwards would be sufficient. It seems like they've actually allowed that type of treatment in at least some of the MDMA trials. So, okay, psychedelics and benzodiazepines aren't ideal to combine, but what does drug tapering of benzodiazepines look like? Well, the withdrawal from benzodiazepines, again, is not only unpleasant, but it's medically dangerous, particularly when people are taking high doses. They've been taking them consistently for long periods of time. So physically, abrupt discontinuation of benzodiazepines can lead to complications like seizures, and seizures can be life-threatening. And this is exactly why heavy benzodiazepine detoxifications recommended to be done in an inpatient, like chemical rehabilitation type of setting or unit, rather than kind of done by yourself at home. The mental symptoms can also be really bothersome when stopping benzodiazepines. So yes, if you're taking it for anxiety, you can probably expect to experience some of that anxiety again. But again, you can get rebound anxiety that is just really intense. So panicking or panic attacks, insomnia is so severe that the person's really at risk for developing a psychiatric crisis. And most people, it's not very many nights of no sleep in a row before things are really going to hit the fan. In the worst kind of cases, stopping benzodiazepines can even trigger things like suicidality, psychosis, or mania. So again, these are some pretty serious risks. And from a set and setting perspective, using psychedelic therapies, having someone that is not sleeping, panicking at baseline, maybe thinking of hurting themselves or, developing psychosis or mania is not a good place to start your psychedelic therapy from. So hopefully this slide speaks to the fact that there are some pretty serious risks of tapering benzodiazepines or stopping benzodiazepines depending on the user. As far as a withdrawal timeline, it typically lasts intensely for 2 to 4 weeks, but this pause or post-acute withdrawal syndrome can last a very long time after stopping benzodiazepines. And some users, will essentially report that, months to even a year afterwards, they're still not quite right. They still haven't quite gone back to their baseline or found a new equilibrium that feels good. So Tapering benzos, are you going to do it? Okay, let's talk about if you're going to do it. Tapering requires customization based on the dose, the frequency used, and how often they use it. Abrupt discontinuation can be very dangerous in some users. Depends on the dose and how often they use it. Longer and slower tapers are the key to success. And as a general rule of thumb, you can taper at rates of 5 to 25% of their starting dose every 1 to 2 weeks as tolerated. I have some resources down here on the bottom of the slide. Some of them are more patient or layman types of resources, like the Empower brochure, whereas Beyond Benzodiazepines and the Pharmacist Toolkit about benzodiazepine tapers are a little bit more detailed, and maybe for practitioners or providers to check out. So 3 categories of benzodiazepine users, and of course you could probably think of more categories, but we had 3 cases, so I thought we could do 3 categories and kind of set them up like a stoplight here. So we've got green, yellow or orange, and red. So our benzodiazepine user that is kind of in the green zone over here, occasional use of low doses on an as-needed basis, less than 3 times a week. It's hard to think that someone that's taking a drug less than 3 times a week has any physical dependence on the substance really at all. There's not going to be a severe withdrawal or even any withdrawal syndrome really predicted. And it would be reasonable to abruptly stop benzodiazepines in this kind of benzodiazepine user. And as far as getting the most out of a psychedelic, tapering or stopping them, I should say, 5 half-lives before the psychedelic experience should be enough. And the 5 half-lives speak for most of the benzodiazepines is going to be around 3 days or 72 hours. People that are kind of in the middle, right? So maybe they're using benzodiazepines on a daily basis. Maybe they're using low to medium doses. Maybe they haven't been taking it for years and years, but they've put together a good string of months that they're taking the medication, and maybe they're on the younger side of things. You are going to predict that there's some level of withdrawal that they're going to go through, and it probably isn't reasonable to abruptly stop that person. But you don't really need to draw tapers out for extended periods of time. You can probably get them off in as little as 4 weeks and maybe 8 weeks if you wanted to take your time and be a little more conservative. 8 weeks, 12.5% per week. Not very aggressive at all. And then you've got the people that are using it daily. Maybe they're using a medium or high dose. They've been using it. It says more than 6 months here, but oftentimes these users of benzodiazepines have been using for years and years and years. As you age, you tend to be more sensitive to withdrawal symptoms. So people over 60 years are at risk of having much worse withdrawal syndromes. And, they may not have a benzodiazepine use disorder, or they may, right? So this is kind of the high dose chronic use type of population here, and you're predicting a severe withdrawal with these types of people. It's definitely not reasonable to stop abruptly, and tapering them off is going to be a long-term process. It's probably going to take months, maybe even up to a year to potentially to safely discontinue their use. So from this presentation, I've discussed so much about benzodiazepines, but I think that this slide is really helpful in that you can kind of look at the profile of benzodiazepine use and kind of like match it to sort of like, okay, well, is it occasional use? Is it chronic use, but maybe not the highest dose or for the longest period of time? Or is this dose pretty high and this person's been taking it for a pretty long time, and or they're on the older side? So okay, maybe they're yellow or red, and maybe you've decided that tapering the benzodiazepine, the risks of that are going to outweigh the benefits to try something like psilocybin-assisted psychotherapy. So what could you do instead? You could consider holding the benzodiazepine, and depending on whether it's a short, intermediate, or long-acting type of benzodiazepine is going to determine when the withdrawal starts and when the withdrawal peaks and how long the withdrawal lasts. So this diagram here shows you that with short-acting benzodiazepines, the onset of withdrawal is pretty rapid and it can peak pretty quickly. Whereas longer-acting benzodiazepines, things like Valium or diazepam, the withdrawal may not even start to set in until 5 days after the person stopped taking their drug or medication. So it could be appropriate and probably not incredibly high risk to hold benzodiazepines at least on the day of their psychedelic assisted therapy. And maybe you could even consider telling them to hold it the night before as well, without running into a severe withdrawal syndrome and kind of encountering all of those kind of scary looking risks that we saw a few slides ago. Minimizing benzodiazepines, I think this strategy kind of comes along with holding them in that, well, we're not going to stop benzodiazepines and we're not going to fully taper benzodiazepines, but maybe we could just lighten the load a little bit around the time of your sessions, around the time that you're doing your psychedelic assisted psychotherapy. So there's kind of a balance to be struck here between recognizing that, well, if we're just going through life, cruising extra comfortably with our normal doses of benzodiazepines, we may be leaving something on the table as far as getting the most out of our psychedelic experiences. However, tapering benzodiazepines all the way could put the person in such a bad withdrawal state that the setting for the psychedelic assisted psychotherapy is kind of ruined, and their experience is also not optimal in that kind of setting or environment. So minimizing benzodiazepines might look like, well, they take the first step in a taper process several days before their psychedelic assisted therapy session, and then maybe hold the benzodiazepine on the day of their session itself, and then they're able to essentially either go back to the dose that they were on, or maybe they want to try to continue on a slightly lower dose after their session. So this could look like decreasing the dose by 25% for 5 to 7 days ahead of time, and then either minimizing use or holding, really trying to minimize the use on the day of the session itself. So that's all I have on benzodiazepines. I do want to quickly touch on gabapentinoids. They don't work directly on GABA. They're more indirect. You can go to forums and find lots of not very specific types of information, like I tried psychedelics and gabapentin and it was strange or it was different, but no one reported it as bad. And some people actually reported that large doses of gabapentin made the come down from MDMA easier. That sounds more like a recreational user than a psychedelic assisted therapy type of use, but interesting nonetheless. Psychedelic trials are weird. So if they are using gabapentin for anxiety, then they had to taper and stop it. But if they were using it for neuropathic pain, then they were allowed to continue it. And some of the trials they've done with psilocybin are for depression and anxiety, people with life-threatening illnesses. These are people that have cancers. Cancers, tumors can push on nerves sometimes and create some pretty nasty neuropathic pain types of syndromes. So I believe it's primarily for that type of population that they're saying, yeah, go ahead and just stay on your gabapentin. It's not worth tapering off of that and being, in horrible amounts of neuropathic pain when you're doing your psilocybin-assisted psychotherapy session. But, maybe you're taking lower doses and you're just taking it as maybe a substitute as a benzodiazepine to manage anxiety, then yeah, maybe you should give it a try as far as tapering off. At least this is what they've done in the study so far. So the withdrawal syndromes are possible with these gabapentinoids like gabapentin or pregabalin, but there's a whole lot less written in literature about what really severe types of things happening, like seizures, which can occur with the benzodiazepines. The Z-hypnotics, so these are sleep aids like Ambien, Zolpidem, or Isopoquone or Lunesta. And, they probably interfere with psychedelics, but at the same time, they're very short acting drugs because they're made to be sleep aids. So essentially, they're made to last for 8 hours or less. And so, they probably aren't really a very big deal and probably aren't going to be this trip killer that really interferes with the therapy and, reduces their ability to participate in psychotherapies before or after. In this kind of case, kind of leave it up to the person. Sleep's pretty important. Probably one night of rough sleep before the session isn't going to make a whole lot of difference. But, telling someone to not use your Ambien for a whole week before a psychedelic-assisted psychotherapy session could leave them in a really rough place as far as insomnia, and they show up to the session exhausted and kind of not in a good place. So with something like a Z-hypnotic, my personal opinion is that you can probably get away with just taking it even the night before your session, but if possible, you can refrain from using it the night before your psychedelic session. That sounds pretty reasonable. And again, they've permitted people to use sleep aids like Zolpidem or Ambien in the week after MDMA-assisted psychotherapy if insomnia is bothering them and doesn't seem to, really be affecting the therapeutic outcomes very much. Withdrawal syndromes are possible for these two, but again, really severe adverse effects, things like seizures, are not reported with discontinuation of the sleep aids like Z-hypnotics. So let's go back to our cases and kind of wrap up or conclude here. So we've got CC here again, and the kind of key here is to recognize that lorazepam, maybe you have to look up what the dosing range is, but 0.5 milligram is not a very high dose. And my God, she's using it so rarely, once every other week. Right? So there's almost no way that CC is physically dependent on benzodiazepines. And she really could try psychedelic therapies at any time. Telling her to refrain from lorazepam use within 3 days of the psychedelic session is, probably pretty reasonable and is not going to be very difficult for CC to accomplish. So that case, I think, is kind of like going back to that slide with the green, orange, and red. She's really in the green zone where it's not a big deal, and you could just abruptly discontinue it and tell her to just hold it for a while before a session. So LB, he was kind of in the middle. He was my case that was maybe correlating with the orange box. And I would say that LB may have some options, right? He is on clonazepam 0.5 milligram twice a day. So he's on a scheduled dose of a benzodiazepine. So he's taking 2 doses on a daily basis. So it is chronic use that we're talking about here. But he's got 6 to 8 weeks until he's planning his MDMA session. And, we said for this type of user, tapering over 4 to 8 weeks is actually a pretty reasonable type of rate to taper. So depending on what LB wanted to do, right, it could be that LB just finished his taper of the Lexapro. He's still feeling a little bit rough and dealing with SSRI withdrawals, and he's a little bit hesitant to go ahead and taper clonazepam right this moment. Okay, so if he did not want to taper clonazepam, I think it would be kind of understandable, coming off of the SSRI recently. So he could just simply minimize his use too. He could taper over the 4 to 8 weeks, or he could just minimize use. Maybe he could try taking, 0.5 milligram 2 times a day is 1 milligram of clonazepam per day. So maybe he could just try taking 0.25 milligram in the morning, keep his 0.5 milligram at night, do 0.75 milligram for 5 to 7 days, maybe before his MDMA experience, and skip his clonazepam on the day of the MDMA treatment, and then he could just resume it the day after if anxiety or insomnia was bothersome. And he probably should resume some of it just to avoid running into a more severe type of benzodiazepine withdrawal in his recovery week after his MDMA session, because that could be confusing for LB, right? Like maybe he has a a really wonderful, deep, insightful MDMA experience, and then feels absolutely horrible the week afterwards with lots of anxiety and lots of insomnia, kind of blames it on the MDMA assisted psychotherapy session when what's really happening is he's in a benzodiazepine withdrawal state. In our last case, this case is, I mean, she's not over 60, but she's 59, right? And she has a long history of severe pain, trauma, surgeries, anxiety, insomnia. So in this case, I would predict that there's probably a fairly high level of dependence on benzodiazepines. And alprazolam or Xanax is a short-acting benzodiazepine that is kind of notorious for having some really hard withdrawal symptoms, even compared to other types of benzodiazepines. And probably with this person's history, stopping use of the benzodiazepine really isn't aligned with what the user's goals are. So yeah, maybe you could lighten the load, right? It says 3 to 4 milligrams of Xanax per night. So you could probably get away with 3 milligrams, like sticking with 3 milligrams for 5 to 7 days ahead of time. You could skip the Ambien the night before the ayahuasca ceremony, and ayahuasca is usually taken at night. So maybe it's reasonable to skip the nighttime Percocet that would be taken essentially while the person's under the influence of ayahuasca. But, probably don't have to rock the boat so much for this person in order to give them a psychedelic experience, because none of their medications, the Percocet, the Xanax, or the Ambien, have dangerous drug interactions in combination with the monoamine oxidase inhibitors of ayahuasca. So I personally would not be worried about some type of severe serotonin syndrome or serotonin toxicity occurring in this person. I will say that Percocet, Xanax, and Ambien are all controlled substances. They're all sedatives. They can have risks in combination with another. And ayahuasca is also a very, very powerful type of psychedelic. If I was the facilitator that was going to pour this person a cup of ayahuasca, I certainly wouldn't be pouring on the biggest or most aggressive cup right off the bat. So I think that that's another thing to think about in a case like this, is like, well, when they actually get to the ayahuasca retreat center, what kind of dosing are we going to do? And probably, just giving this person a taste of the medicine and a lighter type of experience to start with off the bat is pretty reasonable, and maybe a sage approach when people are taking concomitant drugs that are also strongly psychoactive.